तो मैडम आप अभी जब फोन करो मैं आपको कनेक्ट कर देता हूँ वो इंस्पेक्टर वाला बैंक आप मुझे प्लीज मेरा आधार नंबर बता देना Sunita has joined. Yeah. So मेरी मैडम ये ब्लॉक है सिस्टम में सेक्यूरिटी
Hi everyone.
Good evening, ma'am. Sunita.
Hi, hi.
Good evening, ma'am.
Sunita and Bhaskar doing great job.
Sunita is looking at me and laughing. Huh? Sunita is thinking about 1 year back and laughing.
I, I'm done with it.
Recording in progress.
Sharing बंद करो ना यार सबको देखने दो. I can see Malvika, I can see Priya, Subhash, wow,
चलो
Aruna,
चलो
Amod और क्या चाहिए भास्कर तेरे पास? हाँ?
Right. So, ma'am, we are live right now.
Oh, sorry.
So, can we, with the permission of Dr. Bhaskar Pal, Dr. Sindha ma'am, can we start?
Yeah, please.
Yeah. So, good evening and welcome everyone to the fourth episode of ENDOVISION, a captivating webinar series exploring the interesting and controversial topics in endoscopy. I, Dr. Amok Chimote, your host and MOC for today's event. We have an exciting lineup of discussions and insight lined up for you. So before we begin, it is with great pleasure that I extend a warm invitation to Dr. Bhaskar Pal sir, a visionary who initiated the EndoVision webinar series. Dr. Bhaskar sir's dedication to advancing knowledge and collaboration in the field of endoscopy has paved the way for today's event, which features an exceptionally all female faculties. Today's webinar is a testament to Dr. Pal's vision, showcasing the expertise and contribution to the talented women in endoscopy. We are privileged to have a lineup of accomplished female faculty members who will share their insight and expertise with us. So please join me in welcoming Dr. Bhaskar Pal sir as he introduces today's webinar and sets the stage on fire for an enlightening and engaging discussion. We welcome you, Dr. Bhaskar Pal, for the introduction of the webinar.
Thank you. Himanshu, can you stop sharing, please? Good evening, everyone. Welcome you to the endoscopy series, which is the ENDOVISION webinar. India's got such a plethora of endoscopic talent. It is just amazing. We look at the younger people and see that how talented they are. So I think it is always great to have a platform where people can showcase what they're doing. And at the same time, we keep the panel discussions to tell us what not to do. I think there's no dearth of surgical skills, but I think wisdom comes from judgment, and that is what is very important. The idea of having an EVE session is not exactly mine. I think when Dr. Rishma Pai was the president of IAG, Rishma did an EVE conference for the first time. And I remember that we sat and we watched, and essentially it was to provide a platform. Now, I strongly feel that about help, I strongly feel about helping women advancing in medical leadership. It is because I think we men have it easy usually, but women have to balance a lot of things. They have to balance their career, family, and many a time they don't get a chance to put their 100% in an organization as we can. So I think it is a job of our men to make sure that we restore the equality in leadership and also provide women a platform to showcase their talents. So when I became president of IAG, I repeated the EVE conference, and I remember that we had a wonderful EVE conference where women were all the faculty and especially the operating faculty. But today's EVE session is special, is because all the speakers, all the panelists and moderators, and the guest of honor and the chairpersons all are women, and they're all eminent endoscopists. So I thank all of you. I thank my dear friend, Dr. Sunita Tendulkar, for taking her time out to be the guest of honor. Dr. Aruna Tatia, my Arunadi, and Dr. Malvika Sabarwal for being here as chairpersons. Superb endoscopic surgeons, Dr. Mala Raj, Dr. Manjula Anagani, Dr. Sejal Naik, and Dr. Sushila Saini for showing their videos, and Dr. Vidya Bhatt and Dr. Minu Agarwal for moderating the panel discussion, and Dr. Anupama Shetty Arora, Dr. Jayamala Kumaravel, Dr. Priya Gupta, Dr. Priyanka Garg, Dr. Polly Chatterjee, some of whom have seen her. Polly is the best example. Some of you have seen her operate in the EVE endoscopy, but she takes a back seat because she wears too many hands, but a wonderful endoscopic surgeon from Calcutta. We also have the young Dr. Ashwini Kalyankar and Dr. Amrita Tandon. So we have a mix of all ages. Finally, I want to say it is easy to visualize something and dream of something. And the harder part is the implementation, and you cannot implement anything without your team. So I actually would like to thank my co-conveners, Dr. Ashish Kale and Dr. Subhash Malia, and my national coordinators, Dr. Amok Chimote, Dr. Aditi Tandon, Dr. Paushali Shanyal, and Dr. Prerna Keshan. They're the people who actually they execute the whole show. I will be failing in my duties if I don't thank Alembic Pharmaceuticals who actually support this webinar without any commercial interest, and also Conference International who provide the platform and do the entire publicity. Please know that we do run an obs and gynae series also, and we run a fetal medicine series also, and a reproductive endocrinology series also. But the endoscopy series is the highest in live attendance. On both the previous occasions in January, February, and March, every time it has hit more than 500 and once over 600 live attendance. And I always thought that infertility and reproductive endocrinology will be the highest, but I think endoscopy is beating it by at least 100 live viewership every time. So I welcome you all and thank you again. And I will hand it back to Amok for going ahead with the scientific program.
Thank you, sir. That was wonderfully put. So, moving ahead, ladies and gentlemen, it's my privilege to introduce our esteemed guest of honor for today's webinar, Dr. Sunita Tanduarkar, ma'am. Ma'am is a distinguished name in the field of endoscopy and women's health, with a career spanning over decades of excellence and innovation. Ma'am is a highly respected gynecologist, obstetrician, fertility specialist, and an excellent endoscopy surgeon of the country. With her extensive experience and expertise, she has helped countless patients. So, ma'am
Let's
has a lot of achievements, and the biggest one right now is she is the president elect of Foxy. And we congratulate you, ma'am. We are looking forward for your tenure as well.
thank you. Amol,
I think
close down this. Let's close
Sunita,
down this banner.
Sunita, before you start, I always say it's great to speak something which is not there on the slide. And I have had the occasion of working closely with Sunita for 2 years because we were vice presidents of Foxy in the same year. And our seats were next to each other on the dais. And I have also been the secretary of IAG when she was the president. And I think that year, Sunita showed what she can visualize because suddenly in the middle of her term, the COVID hit. And the way she went ahead and visualized the virtual endoscopy series, which was a super hit program. And I think it was easy working with her because I think at the start of the year, we decided that Sunita will decide her work and get everything. And my job was only to execute it and run the office. So it was a pleasure working with her. And thank you, Sunita, for being here today.
Thank you, Bhaskar. I do want to endorse. We had great time for last 1 year, decade. Me and Bhaskar, we are working together as a Foxy Vice President. We enjoyed it with Reshma, and at the same time, during my IAG presidency, I had such a great support by him as a secretary. He was too meticulous in his work as an admin of the office, and he allowed me, Sejal Naik, to be a joint secretary to perform the presidential activity. It was amazing. The way we enjoyed together. I remember the same Wednesdays 1 year ago, or maybe 8 months ago, doing my Pravaha series, but I continued those Pravaha series. Though initially, when you go for a Foxy election, traveling and doing so many webinars, so many personal conferences, physical conferences, attending physical conferences, everything, it becomes a mammoth task. Believe me, and I'm sure Bhaskar will agree with me, that you met so many friends across the country, every society, every city. So out of 47,000 now, if they say, at least 20,000 gynecologists I met personally. And there is always a lot to learn. For Malvika and all those senior most, we have heard them many a time. But I see Priyanka Garg, for example, here from Mirror Society. I came to know about her, her skill, her passion, how she's working, how is her hospital. I know everything about her only because I traveled for my election. So, Bhaskar, at the end, I know you will come out absolutely victorious, but you will be so much rich in your friendship across, which will help you to do a better job as a Foxy president, because these are the chosen diamonds across the country. You will automatically involve them. I just heard Amod talking now. I usually had more interaction with his younger brother, being in a embryology more aggressively, and the way Amod is conducting. And Ashish, today in the evening, I missed your phone call, but it was for the same purpose. Then thank you so much. Yeah, I want to tell Bhaskar, your team was too good, yeah, giving a call and reminding. And when 7 o'clock, still I'm with patient, getting a firing from Bhaskar. You have not joined yet. I gave him authority to fire me because we share such a bond with each other. And Bhaskar, one thing with my experience, let me tell you, and to all the audience, I'm not here to talk about election or influence your mind for an election, but when you choose a Foxy president, you need to understand that's a very responsible post of a huge organization, and you need to select your Foxy president wisely, because it's they are taking the responsibility of ours, medical legal, lot of government problems. You need someone who can lead us and who can take us and who can voice for us in the government sector as well. So I wish you, Bhaskar, all the best. And for your this, I really remembered the Eva when I saw the card, and it will be so great to listen. Mala, Manjula, Sejal, Sushila, they are really the great endoscopic surgeons, and the way Malvika will chair it along with Aruna, I know the question answer discussions also will be great. It is always pleasure to have a panel discussion so that you can not only involve many more people, but you can have many more opinions for a discussion. And I'm sure Vidya is expert in it. Along with Minu, she will do the great justice. So thank you once more making me a part of this very important window vision of a Eva. And Priya is another great leader. Bhaskar, you give a job by morning, the job is done. I'm just telling you how to get the things done with Priya. She will get you the sponsor or everything, everything. She tells me I have to circulate your vision of a president to entire MP and Rajasthan. So I said, okay, how many people will be there? Where shall we send? Who will be doing the printing? She said, all is done. I have everything in my hand. I need your permission to circulate. So this is a leader who thinks of a future and who implement. So probably you all youngsters are the one who will lead the various organization today or tomorrow, whether it is Foxy, whether it is IG, whether it is ISAR or a menopause society. But you will lead it very wisely because you are working with a vision and visionary. Thank you so much. Thank you.
Thank you, Sunita. I just want to remind the audience that after today's Eve Day, the next month is on 8th of May is a different kind of a session. We don't have a panel discussion. That is the Youth Day, and 12 young endoscopists will showcase their work on that day. So that is
Wonderful.
specifically a Youth Day on 8th of May.
Let me remind them, for Bhaskar, I shifted my Pravaha from Wednesday to Thursday, and I decreased the
That's
frequency
right.
for it
That's right.
once in a month. So tomorrow, please join for a Pravaha also.
Sure, ma'am.
Thank you.
Thank you so much, ma'am, for the enlightening words and all your advices for all the future leaders in the field of obstetric and gynecology. So, moving ahead, let's move on to the highly anticipated laparoscopic video session, where we will be witnessing the cutting edge surgical techniques and innovations firsthand. This session promises to be an immersive experience showcasing the artistry and precision of laparoscopic procedure. The primary goal of today's video session is to provide a visual insight into laparoscopic surgeries performed by our excellent and expert female surgeons, and through these videos, we aim to educate and inspire our audience. So, without further ado, I would like to invite the chairpersons of this session, Dr. Malvika Sabarwal ma'am and Dr. Aruna Tanatia ma'am. Dr. Malvika ma'am has always been the voice of a moderator in any laparoscopy workshop. Her lucid explanations and eloquent talk about what is happening in the OT, the pulse of the audience of what they want to understand and know, it is mind blowing. And she has a plethora of achievements to her name. And it would be an injustice to just go and read through the entire CV of man. She actually needs no introduction. So, with that, I welcome Dr. Malvika ma'am. Dr. Aruna ma'am is another exceptional personality, a hardworking person, down to earth, and a people's person. She has always been there to help the youngsters and the colleagues alike, and she has an accomplished career over decades, and she is a wonderful endoscopic surgeon. So with this, I would like to invite both our chairpersons, Dr. Aruna ma'am, Dr. Malvika ma'am, and hand over the first session of laparoscopic video presentation over to them. Thank you so much.
Thank you, Mo, very much. And we are privileged to be here during this session, this endoscopic session. Uh, Today we have a talk by four leading endoscopic surgeons, young leading endoscopic surgeons. The first one is Dr. Mala Raj. So Dr. Mala Raj is the founder secretary of IIT Tamil Nadu chapter, and she's also a managing committee member of IIT, and with lots of other posts also. We not, but she's a wonderful endoscopic surgeon. This is what we know because we have seen her operating on the various workshops, and a wonderful speaker and an orator. And not only that, she is blessed to have a hospital which is doing lots of endoscopic surgery. And so we would be hearing from Mala, basically Bursch corpus suspension, laparoscopic Bursch corpus suspension. Over to Mala.
Thank you so much, madam, for the kind introduction. Good evening, everybody. Can I share my presentation? Yeah. So, good evening, everybody. At the outset, I would like to thank Bhaskar Pal sir and the entire team of ENDOVISION for giving me this wonderful opportunity. It is a great honor and privilege to present in front of everyone. And so, Bosch corpus suspension. Bosch corpus suspension in incontinence ever were introduced in 2001. However, with the advent of the mid-urethral slings, because Bosch corpus suspension started taking a back seat. With time, things evolved. If you really look, first demonstrated this particular procedure. The treatment was mainly approximating the periurethral tissue. And this was demonstrated by Marshall Marchetti Cohen's procedure. However, in a very, very frustrating, this periurethral tissues to the in found it very, very difficult, and ultimately he ended up with. And however, the outcome of very good. And then he started all his SUI procedures. The Bush-Colpo suspension. So this is how it is. There should be at least 2 centimeters in between the sutures, and also the angle of elevation should be 2 centimeters. And this is the landmark paper demonstrated by Bush in his after his publication, after his demonstration on the Bush-Colpo suspension. So ideally, we also need to understand why this procedure seems to be scoring better than that of the other procedures, because of the physiology of alteration which really happens with this particular technique. So ideally, we all know that with the increase in the intra-abdominal pressure, there is an increase in the intravesical pressure, which results in the transmission to the increase in the intraurethral pressure. So however, if the sphincter mechanism is good enough, it is able to hold on to the pressure, and you have a good support of the pelvic floor and the paraurethral tissue, the endopelvic fascia. If it is all taut, this pressure is going to be maintained, and the woman is able to have a continent mechanism. However, in certain women with prolapse, and when she has a very, very weak pelvic floor, when the endopelvic fascia is weak, so the intravesical pressure is not being able to be maintained by the by the sphincter mechanism, and also you can see that there is a drop in the urethra, and the urethra comes and lies outside the abdominal pressure, and she starts leaking. So this pressure transmission theory is mainly responsible for the continent mechanism. And when there is a defect in this transmission theory, there is a leakage of urine, and the woman is not able to hold on to her bladder. So ideally speaking, we try to retain this mechanism by elevating the paraurethral tissue, by fixing it to the Cooper's ligament, and that is where Bush-Colpo suspension plays a very major role. So there are various techniques by which this can be done. Initially, they said that just a single suture is all that is needed, but later it has found that at least a minimum of 2 to 3 sutures is all a must for us to hold on to the pressure. And the current concept is to take at least 2 or 3 bites in the paraurethral tissue. So while doing a Bush-Colpo suspension, the most important step is that how we exactly are able to get into the space of the radius, for which we open the peritoneum in the anterior abdominal wall and then enter the space of the radius. So the best and the safe bet would be to keep the bladder half full. At least about 200 ml of urine should be there in the bladder. So the basic advantage of keeping the bladder full is that because of the gravity, it is able to bring the bladder down. So we don't have to really give any kind of attraction onto the bladder. The bladder is able to suspend itself. So once the bladder is full, we are also able to identify the upper limit of the bladder, so that we are able to safely make an incision on the peritoneum and get into this space quickly. And invariably, this space is very fine space with not much of the blood vessels, but rarely you do encounter some kind of vascularity also in certain cases. So once you enter into the bladder, now the bladder has to be pushed to the opposite side, and you can get into the fascia, where it has to be fixed to the Cooper's ligament. So the assistant in the vaginal end will lift the periurethral tissues with the 2 fingers, and now a stitch has to be taken on the periurethral tissues and fixed to the Cooper's ligament. So ideally speaking, we need to also strip the fat over this endopelvic fascia, so that the bladder is safe and well away from that of the from the suture line. So here you can see that the stitches are now being taken, and you can use the Ethibond non-absorbable suture. So earlier people used the Vicryl, but then it has been found that it is always better to use a non-absorbable suture. So the Ethibond is a best suture material for that. So it has a very, very fine and sturdy needle for us to take a bite on the Cooper's ligament. So at times it becomes a challenge because the angulation is what is the crux where you are taking a bite in this particular area. So we need to lift up the tissues, and then about 2 centimeters lateral to the urethra is what the bite has to be taken. And the distance between the two stitches on the Cooper's ligament again has to be 2 centimeters. So this kind of elevation is all that we need for this particular technique. The most important point what one needs to understand is that you have to only suspend these tissue like a hammock. Too much of tightening of the tissues onto the Cooper's ligament is not mandatory. In fact, it will cause retention of urine. So we need to only just lift up the tissue and being, in fact, it has to be like a suspension of the tissues. So once you take a bite and then suspend it to the Cooper's ligament, the angle will be elevated and you will have a better continent mechanism by holding on to the pressure, and the women will be continent. So here the basic another advantage is that this particular space, when we open up, most of these women will have some amount of weakness and also kind of a prolapse. That is, they can have a lateral cystocele. So further dissection laterally, you can correct the lateral cystocele in the same plane. So that is another major advantage of this particular procedure. So the lateral cystocele can be corrected by taking the paravaginal tissues again and by going up a little more upwards. So once this is done, and you have to make sure the hemostasis is well secured, and finally suture the peritoneum over it. And with that, we have to make sure proper counseling is mandatory for these women, because initially they will say that they are not having that continent mechanism. But what one needs to understand is that it will take at least a minimum of 3 months, because the basic mechanism is only by fibrosis. It is not just with the elevation. So for the fibrosis to occur and for the women to feel the real good continence on the her bladder, it will take minimum 3 months. So we need to give her proper counseling post-operative period. So sometimes we also encounter certain difficult situations where we have to do a TLH for these women, like in a ventral suspended uterus, and where the total anatomy is distorted. And you can see here the bladder here the uterus was totally stuck to the bladder, and it was attached to the anterior abdominal wall. So here you can see that the uterus was mobilized first and then brought back to its normal position. So as a result, we lost the plane of for the plane of space of Retzius. So here you can see that after finding the plane of Retzius, because this uterus was really obliterating the space of the Retzius. So laterally, we have to find the space and get into the plane. So there are situations where you can encounter difficulty like this. Not all cases would be smooth. There are sometimes you have challenges during this particular procedure as well. And also there are chances of complications of bleeding, because it is quite a vascular area as you move laterally from the center. So here you can see that the Cooper's ligament are visualized. The moment you see the Cooper's ligament, you know for sure you are on the right track, and then keep dissecting that right down to the endopelvic fascia. So further creates the platform for you to fix the endopelvic, the suture. And then identify the endopelvic fascia in the paraurethral region and fix the suture to the Cooper's ligament. So here you can again see that the bladder is being mobilized, and then the sutures are being taken, and the angle is being elevated. So even in difficult scenarios like this particular procedures can be done in a same sitting, so that you can avoid two sitting, and the women would benefit from this particular procedure. So this is again, you can see that in a complicated situation also you can do this procedure. But this is again another video where you have to also know that sometimes you can encounter complications, and how are we going to manage these complications. So that is the reason I have posted this particular video. So here you can see that it all looked like a simple procedure. The bladder, you can see the bladder is being filled up, and you are making an incision on to the peritoneum. So this kind of filling of the bladder will give us an idea where exactly we can make the incision. So once the bladder is filled up, just make an incision onto the peritoneum and you can enter into the space of the radius. It's a beautiful plane to dissect because the connective tissues are so nice, and you can dissect nicely in this tissue and extend this laterally. And once you do this, and you can see that you can identify the Cooper's ligament. But here, what one needs to understand that once you dissect on the Cooper's ligament, you have to be very, very careful because you have vital structures. You have the obturator bundle, I mean nerves, and also the external iliac vessels. So this is what exactly happened in this particular case. It was quite vascular, and as I was dissecting and mobilizing the bladder and also taking a stitch onto the urethral tissue and to the Cooper's ligament, and you can see there was a bleeding which was encountered. So as the stitch was being made, and you can now see that there was a ooze lateral to this particular stitch, because here you can see that I mean, what we need to understand is that the obturator nerves are about 2.8 centimeters lateral to the Cooper's ligament, and the external iliac vessels are about 2.8 centimeters. So this kind of anatomy we need to understand, and then you can encounter this kind of bleeding sometimes. So we have to be very, very careful while taking stitches in this particular area. But if we have to encounter a complication, we also need to know how to tackle them. So all that we need to understand the anatomy, and here again the corona mortis can also be encountered further lower down. So we have to be vigilant enough and cauterize these bleeders carefully and proceed with the procedure. So here the bleeder is being cauterized, and then you have to complete the procedure. But what one need to understand is that if you encounter any kind of a bleeding like that after the procedure, it is better not to suture the peritoneum, better to leave this open, because this will be an open space for drainage, and you can put a drain and come out. So this way you can also use some kind of a hemostatic agents to also make sure that the hemostasis is well secured, because it is now a very vascular area. So how successful is Birch-Kalpoe suspension? Of course, we also go by evidence before we embark into any particular technique. Of course, Cochrane review states that the cure rate is about 68.9% to 88%, and the recurrence rate have been found to be quite low. The cure rate of retropubic suspension technique in general is quite steady in even up to 10 years, from 90% at 1 year to 70% by 10 years post-operatively. However, after 10 years, they say that there is a slight decline by about 65 to 20% at 20 years. So the recent Cochrane review about laparoscopic Kalpoe suspension and the open Birch-Kalpoe suspension were done, and however, Cochrane did find that the laparoscopy scored over the open on a marginal difference because of the various benefit of laparoscopic surgery. So various authors demonstrated a very, very small meager difference between the two procedure of like 97% and 96%. So the benefits of Birch-Kalpoe suspension is that it increases the functional urethral length. It also increases the urethral closure pressure, which is the reason no other continent procedures achieve the comparable degree of reliance. And also it is able to treat the milder forms of anterior vaginal prolapse. So for sufficient mobility and capacity of the vagina, however, is a prerequisite for this particular procedure. So we need to make sure that the vagina is also mobile before embarking onto this particular technique. So these are the various literatures where they have compared various techniques of Birch-Kalpoe suspension, whether a transperitoneal approach was better than the extraperitoneal approach, and whether a suture is better than the mesh. However, they found that only the sutures are better than the mesh, which is about 91% versus 94%, and also whether the open and the laparoscopic procedure, the comparison was done, and they found that the lap was much better than the open, and whether the sutures, like whether you take a two bite suture or a single bite suture, and they found that double bite suture is much better than single sutures. So all this evidence here to prove that the laparoscopic Birch Calippo suspension seems to be a very promising procedure, and this is a very large study of about 14 years where they found that laparoscopic Birch seems to be a very good procedure for stress urinary incontinence, and the anatomical relationship of this particular procedure with the vital structures have also been studied, and they found that the Cooper's ligament is very closely associated with the obturator bundle and the external iliac vessels, and as a result we need to be quite cautious. But the anatomy, if you are familiar, then you can avoid all of these damages. So to conclude, all the various consensus statements of the recognized scientific societies have established stated that mid-urethral strings have safely been used. The media pressure, however, is boosting the comeback of laparoscopic Birch Calippo suspension as a first-line surgical treatment for female stress urinary incontinence. So thank you so much for this wonderful opportunity, and I'm open for questions. I once again thank Dr. Bhaskar Pal sir, Sunita madam, Aruna Tantia madam, and Malvika Sabharwal and the entire team of ENDOVISION for giving me this wonderful opportunity.
Aruna, that was Mala, that was an excellent video, an excellent talk. You brought forward all the points beautifully.
Yeah, thank you so much.
Tell me something, Mala.
Yeah.
As a routine, in case a patient was to come to you who needs a hysterectomy and also has SUI, what would be your suggestion?
Yeah. See, now when I'm so earlier I was doing the mid-urethral slings, ma'am, but now I'm quite comfortable doing this Birch. So because it is, a single approach, I finished my TLH, like one of the videos I have showed, I finished the TLH and I do now the Birch. Because now it hardly takes like extra like 40 minutes or 45 minutes for us to do the procedure. And also, the complication of the slings and also the fear of erosions, all that are not there. So that is a reason, like now I am slowly moving off to a Birch rather than the sling procedures.
So in your experience, what was the complication of the
Pardon, ma'am?
For your mid-urethral slings, what was the complication rate in your experience?
Mid-urethral slings, as such, I was quite comfortable. But, now patients themselves are quite aware. Like, they relate everything to mesh. They know for sure that mesh is not being used now for any of these procedures, especially in the vaginal route. So when you offer them, like now I want to do a Birch. It is not that, the patient also is asking. I basically want to do a Birch for my patients. So when I talk to them, like these are the advantages over the sling procedures, they are very convinced. So automatically, they are not going to have anything in the vagina, and the complications of the mesh erosions, all those things are not there at all. So it is, I very safe. It's all about how we talk to the patient, how we convince ultimately.
Yeah, and Mala, actually, even if one case you see of a vaginal, it's something coming through the vagina and you have that kind of a complication, and the patient is cursing so much, it is enough to make you immediately move on to your next skills of commanding the Birch.
Yes, very true, madam. Especially the mesh, what happens was, like, I mean, in the mid-urethral sling, the point where the exit point, the junction between the urethra and the lateral angle where it is coming. So that time, sometimes you can feel the mesh. You can feel the mesh, and for a couple of patients, I had to, in fact, trim and cut it off,
Exactly. So
the biggest headache. Yeah,
yes.
so that is the biggest problem. So it not complete erosion. The joint where it is entering into the vagina, that portion hurts them. So you have to, trim that bit, and all that is not there when you do this laparoscopic. So
do you normally do a cystoscopy after doing your Birch?
Birch, ideally speaking, not for all cases, but if you have any difficulty, like, the second case which I showed you, where there was so much of additions there, where the uterus was entirely plastered, to make sure, like, I have not gotten anywhere, I generally do that. Otherwise, not for the routine cases.
So I think that was
Mala, has there been any experience using proline as a suture? Since when did you start? I
Yeah,
think.
so Ethibond, I am very happy, ma'am, because while you take a bite on the Cooper's ligament, the needle of Ethibond is very, very nice. It is nice and
Strong.
sharp. Unlike your proline needle, proline, of course, is fine for other areas, but to take a bite on the Cooper's ligament, the Ethibond needle are much better.
Yeah.
Lot more sturdy and also very
That
sharp.
makes a
So it is, yeah, the ease of taking the bite is much comfortable with the
and
Ethibond.
moreover, it has a proline has a memory also, quite a lot
Yeah,
of memory.
exactly. Yeah, that is also
Proline
there.
not
And this
is
is
quite cumbersome.
fine. Yeah, true, madam.
Yeah. So, in case of when you encounter any bleeding in the triangle of doom, that is where there are lots of vessels, etc. So, what is the basically what energy source have you used whenever you have faced it?
Yeah, bipolar only, ma'am. When there is a bleeder, it has, I use bipolar. That is, point coagulation. The spurter alone
Yeah.
to just, cauterize and then manage it.
Right. Thank you. Excellent presentation, Mala.
Yeah, thank
It's
yeah,
you.
really been a good presentation, giving the fine nuisance of the surgeries,
Thank
and
you.
definitely it is a great result for the patient who keep on becoming incontinent and shunning public life also because of the incontinence. They are able to go back to the life after this small surgery that can be done along with the TLF if required.
Yeah, madam. Yeah, thank you
so.
so much.
So, Arnav, shall we move on to the next?
Sure,
Yeah.
sure.
Arnav, shall we move on to the next? So, we have an excellent talk now on your avenues in gynecological endoscopy by none other but Dr. Manjula. We all know her. She needs actually no introduction. She's a consultant and laparoscopic and robotic surgeon, a urogynecologist, an oncosurgeon, and overall, and a Padma Shri 2015 for distinguished service in the field of medicine by the President of India. She's from Hyderabad. We all know that. She is the director, HOD, Care Vatsale, Women and Child Institute, Care Hospitals, Hyderabad. Manjula, we are really looking forward to your talk because we know when we started laparoscopic surgery, it was just a simple diagnostic modality. That was the way it actually started. Then the ligation and then small variances being managed, and very soon it kept growing. And today, from east to west, it's grown so much with all the advances of minimal, and we all know the advantages of minimal access surgery. And beside that, the technology going up, the skills which are actually growing so beautifully. Everybody is commanding with all these, like today's webinar, we are actually disseminating all what we have learned, and we are talking about all those things with panel discussion and all this. So we are actually, learning fast, we are disseminating fast, and this is the way to tackle most of the gynec problems. You just think when it was approached like 1910, when it was first introduced by Han Christian in Stockholm, and he coined the term laparoscopy. And from there, 40 years, 4 decades later, it was really spreading in Europe. And I remember when I went to Europe, I went to Dr. Adebagos in London, Dr. Bamsticker, just to learn the skills. We were fascinated by watching them. Dr. Bamsticker had come to Bombay. I watched him, I followed him to a place called Haarlem near Amsterdam. Then I followed Dr. Adam Begos. So the skills have improved so much. Today, oncosurgery, look at everything with technology going so high. Look at the 3Ds which are available. Look at the robots. So all this are the skills. Now we are looking forward to listening to you, Manjula, in all your newer avenues in gynecological endoscopy. So over to you, Manjula.
Sorry to inform you, ma'am. Dr. Manjula just messaged that she's not well, so she won't be able to join. So we can move on to the next speaker.
Okay, that is quite a loss actually. We
Yeah.
were really looking forward because this is a very, very interesting talk. I was looking
Right, right,
forward.
ma'am.
So, anyways, Aruna, go ahead and call the next speaker.
Ma'am, kindly unmute yourself, please. Aruna, ma'am.
Hi, welcome, Dr. Sejal Nayak. It's lovely to have you on board over here in this session. Dr. Sejal Nayak is a GEM member, has received a GEM member award from MIG in 2022, even a Best Paper award from All India Congress. She is a managing committee member of IAG from 18 to 24 with active participation in various projects. We have seen her organizing a conference so beautifully, and also she worked very hard with Dr. Sunita Tendulkar when she was the president. And Sejal is also an excellent endoscopic surgeon and has been invited as operating faculty in both international as well as national live workshops and conferences. And she has, to her credit, many papers in international and national journals and has written many chapters in the book. We are really looking forward to see Dr. Sagel's work in the field of hysteroscopy. Especially, she'll be talking of fertility enhancing hysteroscopic surgery, which is definitely a surgery to look forward for all infertile women. And with infertility on the rise, we must know the uses of fertility enhancing surgery. Over to Sejal.
Thank you, Aruna ma'am. Thank you so much for the kind words. Can I start my screen share? Uh, at the outset, I would like to thank entire team and Dr. Bhaskar Pal sir uh, for inviting me here. That's a special this I cannot special EU session here, and all best endoscopic female surgeon across the country are here, and I am so glad to be the part of the this webinar, and I really wish Dr. Bhaskar Pal sir all the very best for his presidential campaign.
You
So
organized the endoscopy conference last time.
yes, thank you so much, ma'am, and we missed you there.
Yes.
So. Today I'm going to discuss about the fertility enhancing hysteroscopic surgeries. And we all know that only 30 to 40% of the gynecologists they perform the operative hysteroscopic procedure. Why? Are they lack in training, or they are fear of complications, or they have previous experience of failed attempts? In the contrary, they are almost all doing the blind similar procedure, that is the BNC. So let us now we enter the cave which we fear the most because it holds the treasure that we seek. So hysteroscopy has its own role in endoscopy, in infertility, where it is the truly minimally invasive. To have the successful outcome of the hysteroscopic any procedure, the priority remains with the proper diagnosis pre-handedly, that is by the ultrasound and preferably by the surgeon himself. So that decides the extensiveness of the disease, the number of sittings she may require, that helps in the proper planning of the surgery, the required equipments, instruments, and the proper counseling also. So one of the most common procedure for hysteroscopy is there is maybe sometimes there is a difficulty in negotiation of intrauterine catheter or IUI catheter or ET catheter because of the stenosis. Ultrasound guided can be performed dilatation of the internal loss, that can be beautifully done with the added hysteroscopy simultaneously, that allows the fluid to distend the endometrial cavity and correct plane of entering. So what else can be done to overcome the difficulty in entering? So one can change the hysteroscope to the narrow caliber. One can remove the outer sheet and only the inner sheet with the inflow can be used. We can use the traction at the angle cervix to correct the angle of uterocervical length, and one can use the other solutions like vasopressin, etc. We can do the cut the fibers of the internal os with the scissors and can dilate the little bit internal os and can enter under vision. Infection is very much common cause of infertility, especially in the country like India. where the tubal occlusion and the endometritis are really very common scenario and the reason for the infertility. The degree of infection, see, more the severe, the more higher chances of tubal occlusion, and the number of episodes, that the more the episodes of salpingitis leads to more chances of tubal occlusion. So tubal cannulation can be performed hysteroscopically for the patients who are trying naturally or for the IUI, where the salpingitis occurs in the estimated 15% of the reproductive age group female and 2.5% of the all women become infertile as a result of salpingitis by the age of 35. So cannulation can be performed with the cannulation catheter or the novice catheter at placed near the ostia, and the guide wire is passed through the interstitial layer of the part of the tube. Guide wire doesn't need to pass beyond because it is only for the corneal occlusion. It may lead to perforation or the injury of the tubal mucosa, and the selective tubal chromoperturbation can be performed. Another outcome of the infection or maybe the iatrogenic due to the DNC or any injury to the endometrium can lead to intrauterine adhesions or the synechia. Hysteroscopy is gold standard for diagnosis and management of uterine synechia. Pregnancy rates about 74% post-procedure has been noted, while untreated women will be nearly 46%. The one of the most challenging hysteroscopic procedure is this Asherman syndrome, where the complete plastered endometrium is there and where the anatomical landmarks are being lost. This is usually followed by the hormone replacement treatment, and patient is counseled for maybe requirement of the repeated procedure. So intrauterine foreign body or the retained products of previous abortions can be the reason for her of infertility, which can easily be managed with the hysteroscopy, where the thread is lost and one is unable to pull out the device or the material. Here is the case where the polyp is simultaneously removed, detached from the base of its pedicle with the scissors, and the polyp and the vertical arm of the copperty, which was the thread was missed here. You can see the thread was broken here, can be removed and grasped with the polypectomy forceps. Polyps are one of the common lesions. They are found in 2 to 3% of the infertile women, and they are associated with the poor reproductive outcome, including reducing live birth rate and increase the miscarriage rate. And after polypectomy, pregnancy rate can be increased to 63% compared to if it is not removed. Such a large polyps can be may not be removed with the scissors, may require the resectoscope here and slicing out of the polyp at the from the base. Complete removal is required, because if such a big polyp, if we remove cut from the base, then it is difficult to remove the entire material from the uterine cavity, and that is how we can make the splicing of the polyp. Fibroids accounts for approximately 5 to 10% of the infertile women, and we know that fibroids are not all fibroids are responsible for her infertility. It can be the sole cause of infertility in only 2 to 3% of the women, especially the submucosal fibroid, the FIGO classification type 0, which is pedunculated inside, the type 1, where this majority part is lying inside the cavity, type 2, where 50% is inside the cavity and 50% is in the myometrium, and sometimes type 3, which indent the cavity on this endometrial layer. So this can be the mainly responsible fibroids which can be removed hysteroscopically, where here you can see when the diagnostic hysteroscopy is performed, there was no bulge, but as soon as we reduce the pressure, you can see the bulge is coming up. We mark the area of that bulge under low pressure, and then we increase the pressure to start the myomectomy and the resection of the fibroid. By the reducing and increasing the intrauterine pressure, the uterine myometric contracts and push the fibroid more inside the cavity and can be easily detached. And you can see here it was a really very deep-seated fibroid, and we'll play again. So this marks using the cold loop to dig out from the base of the capsule, the fibroids will come out with reducing the minimum damage to the surrounding myometrium, and this can be completely procedure can be complete with the hysteroscopy itself. Uterine septum per se has controversial role in infertile patient, but it significantly resection of the septum improves the pregnancy rates and live birth rates in recurrent pregnancy loss patients. The lower the number of pregnancies after hysteroscopic metroplasty, with low birth weight being the comparable because of it reduces the miscarriage rate. But it seems to be beneficial to infertile women, those who are planning to undergo IVF, and especially to those without any other known infertility factors. So, in septum can be partial or can be complete. 3D ultrasound, we operatively usually differentiate between the biconate or the septate uterus. The complete septum is advisable to perforate at the level of lower segment where it is thinnest. One can put the Foley's catheter in another cavity and then can perforate with either scissor or the Collins knife. Septum can be resected as per the in the midline and can be used with the scissor or the electric energy sources. Depending upon its consistency, maybe the fibrous or the fibromuscular. For the septum, under correction is better than the overcorrection. And at the internal os, if you visualize the panoramic view, the both ostia, if seen at in one line, that is the end point of the procedure, and the laparoscopy simultaneously can help and to complete the procedure without any complication. Another is the cystic adenomyoma, that is bulging inside the cavity. As the adenomyoma is prevalent in 25% of the patient at the age of more than 40 and like 77.5 to 22% of the patient below 40 years, with delaying the age of marriage and the childbearing with the career and other reasons for the female to bury the kids, children late, the incidence of this adenomyoma is increasing, that is damaging the mainly causing the implantation difficulties, can be easily managed with the hysteroscopically, where you can see after the cystic lesions are seen inside the cavity, and on the dissection of this lesion there the chocolate material is coming out through these cavitations, and that can be completely excised, and the endometrial cells there can be like fulgurated. Endometrial malignancy is not that common with the infertility, but approximately the 7% of these cancers, they are occurring below the 45 years of age, and with increasing the age of fertility, we are seeing more cases. Hysteroscopy can help in getting the biopsy of this tissue sampling uh, in suspicious cases of endometrial malignancies. So widening the horizon of use of hysteroscopy that can be used for a PRP or stem cell subendothelial insemination, and it has been still under the trial. Still more evidence are needed to prove its role for the thin endometrium, where hormone replacement therapy has the not has given the good thickness of the endometrium. So after this procedure of subendothelial PRP or stem cell insemination, the data supports the thickness has been increased in 75% of the patients for more than 7 mm, and yet to prove in a clinical practice. So still we are doing it under the experimental basis. So I would like to conclude my talk with the hysteroscopy is an answer to a variety of fertility issues. It's an art of ART, And hysteroscopy is very safe procedure. Complications rates are noted less than 2% in operative procedure, and major complications are less than 1%. And the surgeon skills remain the best safety measure in operative procedures. So better to get ourselves trained properly and do not enter until and unless we get the proper training under our experts, and that is the carry home message. So here I would like to thank you everyone, and would like to urge and request for supporting me for candidature of chairperson Foxy Endoscopy Committee. Thank you.
Dr. Sejal, that was such an excellent talk. Really, very, very good. And let me tell you, I'll just share one point with you. The year was 1992 when I did my first hysteroscopic workshop in Delhi. And when I invited everybody, right from Dr. Ghai Bhandari to everybody, they said, hysteroscopy will not come and will not stay. So I said, if it is being done in Europe, so we have to do it. And we will run it down. But that was the beginning of it all. And I think it's amazing that I still go high on every procedure. And Sejal, you showed a plethora of procedures, which was excellent, right from a simple polyp to removal of a copper T to the adenomyoma. Excellent. One
Thank you.
important point, Sejal. So the tip which I would like everybody to take is that your team has to be very much involved. When you do a hysteroscopic procedure, you have to be strict with your team. The anesthesia person in our OT has to get involved because the inflow and the output has to be measured very correctly. Especially those were the days when we were doing TCRU. So, you have to be so strict. But today, when you're doing a fibroid removal, etc., the most important thing is to have a good team, especially your OT staff, which gets involved. So that is very, very important. And Aruna, would you like to ask some questions?
Thank you, ma'am. Thank you, ma'am.
I think, Sejal, it was really a very good presentation. You showed all the complete spectrum of the procedures that we can do hysteroscopically. And today I remember very well when I initially went for my training, and I was bent upon not learning hysteroscopy at that time. I kept myself away from hysteroscopy, but later on realized how important it is to do a hysteroscopy also and do hysteroscopy procedure. So I started picking up hysteroscopic technique later on. So it was really very nice, and a very simple procedure would definitely help in enhancing the fertility of a woman. Not only that, many times, even like when you're not sure of the diagnosis, maybe she's having a post, even in case of you are talking about fertility enhancing, but I'm talking about non-fertility enhancing also. When a patient is presenting with a postmenopausal bleeding or something, and if you go and if you encounter a polyp, and that is what you really require to take out and send it for biopsy, whereas otherwise she would land up into an abdominal surgery only. So
Absolutely. Yeah.
surprise that we definitely can be resolved by hysteroscopy. Thank you very much. And is there any more questions from any of the other doctors?
One very important thing, Sejal, you said that to tackle the internal loss, can be very difficult. And I've had situations where I've used scissors, just like you showed. This is something wherein we all must understand. You may not have an ultrasound in the operation theater. One must do a simple pelvic examination to assess what is the relation of the uterus, whether it's anteverted, retroverted, or where, and accordingly just proceed on. And it will start with the smallest of dilators and use half dilators, which is very, very important. And I think for fibroids again, which is the largest fibroid? What is the size of fibroid, Sejal, that you recommend doing hysteroscopically? The submucous type 0, type 1, type 2. So what is
Madam,
the
it completely depends upon your expertise and the speed of surgery, because the volume overload occurs very faster than we expect. So, if one is new, should begin with the 0.5 to 1 centimeter, and one can exhale up to like 5 to 6 centimeter, provided you have explained her possibility of 2 sittings.
Yes.
So,
Yes,
Yeah.
would you like to do a 5 to 6 centimeter in one sitting or two sitting?
So provided I will like to finish it in one go for patient, but provided if it is safer for her in respect to the volume deficit, so I would always counsel patient and take the consent on paper that we may not able to remove the complete fibroid, and you may require the second sitting if it is so.
Many times they spontaneously just extrude out the remaining portion of the fibroid also if we just do half of it, and because the amount of bleeding that she's been having a heavy period does decrease, and later on the half of the portion that is left behind gets extruded by itself.
You
So
know,
she
Sejal,
will not require the second procedure too.
Sejal, you have shown very nicely how you, even with a cold resectoscope, I mean, with the loop you have taken out at the base, which was a very important thing which we have used. You've removed the fibroid and then gone, like you're excavating the fibroid from the base, which was very well done. And
It's like
uh,
taking
uh,
out.
yeah,
Scooping it.
so yeah, exactly. You've scooped it out. So reducing the intrauterine pressure and increasing it also helps. It pushes, or the use of a syntrocenon injection or a prostaglandin, or these things do help to push the remaining fibroid inside, and you can complete the job. Especially if you're using saline, and you can use. But the only thing, personally, I feel that when I use a bipolar resectoscope with saline, I can do a procedure, but it is a little slow. So I always land up doing a unipolar resectoscope, doing, especially.
The problem occurs with this hydro massage where you reduce the pressure and then again increase and then reduce. It will helps in popping out the fibroid inside the cavity, but it also makes your field of vision very blurry. So you
Mm.
require certain more time. You have to keep on intermittently suction on and off, and then you have to have the clear vision in between. So you have to wait for a while. So means there is a two-way. It may little bit increase the time of your procedure.
So
Yes.
have you ever had a very difficult hysteroscopy where you could find it very difficult to negotiate through the internal? What is your tips to the viewers?
So the same when only the one case where it was expected to be the plastered like Escherman complete amenorrhea following the DNC, where we couldn't enter at all through the apart from the external cervix and the cervical canal, we couldn't go in. We had to abandon the case, but it was the end organ failure, and we explained the patient, okay, in this we are unable to open up the any, like there was no endometrium, there is no entering inside. So that was the only case we kept for the workshop, and unfortunately we couldn't do any, we couldn't accomplish the case. Otherwise, whatever we can use the laparoscopy also to guide our direction of the dilator or the sound. Ultrasound guided we have tried, and there is nothing major with the when there is a big endometrium or the big fibroid and the uterus is completely retroverted, retroflex, or the frozen pelvis, it causes difficulty in hysteroscopy negotiation, where we do the correction first. We do remove the adhesions first, we remove the fibroid first, and then we can do the hysteroscopy.
Okay. And one other thing, Aruna, I would like to share, you asking that. I've loaded a syringe and put in saline into the little tip which I feel may be the os, and I dilate it with that, just like you do with the fluid, using
But
a
you
machine.
when you do a vaginoscopy and the jet of the pressure of the
Yes,
water, it just opens up the external os, which is practically quite tightly closed. With just a jet of water, it does help. Vaginoscopy definitely helps in such cases.
yes. But पता है पूरा नहीं होता ना. You have to, because I'm actually talking about not infertility. I'm talking about menopausal lady. So those kind of, they are very difficult to negotiate, and in such cases you have to just hold whatever you get, because cervix is totally so. It's not applicable today in our talk. But anyway, I just to share that I use to a syringe which is filled with saline, and pushed it with with a needle. just with a needle, just to make a passage, and then slowly and gently go in with a sound. And that's the way to do it. Anyways, it can be very difficult, and failure is something that you don't want to do in a hysteroscopic procedure, right?
Meenu ma'am wanted to add something, ma'am.
Actually,
Yeah.
just a simple tip that if you have done the protruding part of the fibroid and you're not able to get in, so what you did was very nice. You reduced the pressure, increased the pressure. One thing which I find very useful is you remove the entire contraption and just do a bimanual massage
Yes.
for a couple of minutes and then go back again, and you will find that that fibroid is popping in again. So that also helps for.
Yeah, that's a very good way of bimanual massage, or using any of those uterine for uterus, contracting the uterus, and I think that really helps. And of course, we have to explain the two sittings. What Aruna you were talking about, we always explain about the two sitting procedure in a large fibroid because in case you've explained it earlier in a pre-op period, the patient is prepared that I will have a two-stage procedure. So I think we've used Manjula's time very appropriately, and we can move on to the next. What do you say, Aruna? So
Yes,
we've had
absolutely.
Thank you, ma'am.
questions and so many. So we
Thank
are
you.
now
Can
moving
I
on.
add, ma'am? Can I say something?
Mala?
Madam, in such difficult cases or little slightly bigger myoma, what generally I do is I inject vasopressin into the myoma.
Yes.
Using the oocyte retriever needle, you can just, take the needle and inject it onto the myoma. So it becomes very easy for us to resect it. So the basic advantage of vasopressin is it not only makes the procedure a single sitting procedure, the chances of fluid absorption is relatively less when you use vasopressin. So that is another advantage of that particular procedure, and you can do it in a single sitting also. And in case when you have a tight os, a stenosed os, I again inject vasopressin or sensacane at the level of the os, internal os. So you can see that slowly the os opens up very nicely. So after we just wait for a couple of minutes and then reintroduce the scope, you'll be able to go in without much difficulty. So these are the two things generally I do when I encounter some difficulties.
Manu, do you also inject the vasopressin in the cervix to decrease any blood?
Sometimes when there is a tight os, I inject vasopressin onto the cervix. But
No,
when
even
even
private
myomectomy also you can do that. Sometimes I even
increase the bleeding.
yeah, it reduces the bleeding. Yeah, it reduces the bleeding. It makes the myoma soft, so it is very comfortable for you to resect. There is a chance for reduction in the fluid absorption also. So all these benefits are there.
Actually, I just want to add a point here. What Mala said, I 100% agree. That's basically because vasopressin injection gives very good results. I have a publication on that, wherein you will have a nice clear vision because there's no bleeding. Second thing is your operating time is reduced because if it keeps on bleeding, you suck it and then you once
Exactly.
again give distension, so your operating time is reduced. And also you can get into the planes well because you have a vasopressin creates a plane. And one more point, what you can do is when you have a myoma like this, you take the Collins knife and make an incision, which is described by, I think, the a surgeon from this Lasmar. Dr. Lasmar has described this, the senior Lasmar, wherein you make an incision and the capsule opens up. The myoma, you increase the pressure and decrease the pressure, it just pops out.
Yeah.
So that is also another advantage of doing giving vasopressin and making an incision. The moment you cut the capsule and as the pressure decreases and increases, there is contractions and your myomectomy becomes very easy. Thank you so much.
Wonderful, ma'am.
I have also
Ma'am,
used myoma
quickly,
screw sometimes to pull it. Hysteroscopic myoma screw. I don't know how many have the experience, but I have used it. It is a very delicate instrument. You cannot make it. You cannot pull it completely. But from Figo 2 to Figo 1 or Figo 1 to 0, you can slightly pull it, then remove the myoma screw, pull the
Yes.
spectroscope again, and resect it. Amol, yes, please go ahead.
yeah,
Sorry.
ma'am, I'm really sorry to interrupt, but it's a very exciting discussion going on, sparked about by the wonderful lecture by Dr. Sejal, ma'am. But due to the shortage of time, I request the chairpersons that if you could move on to the next talk.
Thank you, Dr. Book. So we move on to the next, which is
Sorry.
another important talk. May
Dr.
I
Shushila.
the next talk is extremely important. It is on laparoscopic pectopexy, a novel approach to prolapse. And we know how common prolapse is, especially after the age of 50 years. There are so many people who do have prolapse, and we do not, they are socially under a stigma. They are feeling uncomfortable. They're not happy with themselves. So this is something which needs to be looked into. And this is laparoscopic pectopexy, which is something which is, it's a novel approach of vaginal prolapse, which was described first in 2007. It offers a clear practical advantage compared with laparoscopic sacrocolpopexy, what we have been familiar with for a long time. And we've also faced a lot of problems, whether it was a chronic pain, a defecation problem, or a urinary problem, with so many complaints. But with this particular approach, we are now waiting to hear what our dear Dr. Sushila said is going to tell us about it, because it is something which it's definitely easier to command as compared to the other procedure. And it is not only easier to command, it also has lesser complications. So Dr. Sushila Saini, who is the founder director of Jaipur Doorbeen Hospital, and the chief editor and publisher of Step by Step Approach to Learning the Art of Gynec Endoscopy book, founder president of Association of Gynec Endoscopic Surgeons of Rajasthan. She's also the founder secretary of IAG Rajasthan chapter, vice chairperson for IAG Rajasthan chapter, and so many things to her credit. She has been going left, right, and center, operating in all the various conferences, whether Eve or otherwise. So, Sheila, we are waiting to hear you. The stage is all yours. I hope Sushila's there.
Welcome, Shushila. Yeah, Shushila was there. Shushila has to unmute.
Yeah, hello.
Yes,
Hi, Shushila.
Welcome.
Hello, ma'am. How are you?
Very well, Sushila.
हेलो मैम मैं फ्रांस आई हुई थी एक्चुअली थोड़ा
I know.
सोहान सर के पास
आ रहे हो अब फ्रांस में हो कि अब आ गए हो वापस?
नहीं नहीं फ्रांस में ही हूँ वहीं पे उन्हीं के रूम से वहीं से प्रेजेंट कर रही थी
कहाँ पे?
फ्रांस में बोर्डोक्स में होरास रोमान सर हैं एंडोमेट्रियोसिस के लिए
ठीक है ओके
हाँ 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 जी मैम
हाँ जी
सो शुड हेलो
आप शुरू करिए
Shushila, go ahead.
Yes. So my talk given is on the laparoscopic pectopexy, as I think everybody listened my talk already. That is, we are regularly doing the pectopexys, and the person who is changing the slide, please change the next to the slide. Yes. So from age-old technique, we are doing the laparoscopic sacrocolpopexy, which is a gold standard till now. But nowadays, there may be problems with the sacrocolpopexy, and in these kind of the common situations where you are seeing on the PPT that there may be the promontory osteostitis, or there may be the big vein problem there, or many time a failure. Or in an obese patient, we cannot approach to the promontory. So that time we need a other technique also in our portfolio, because one technique cannot fit to all. So next technique we actually approach is the pectopexy. So just next slide. Slide change, please. So it is recommended for experience of the laparoscopic surgeon that if there is any difficulty, then we can go for the pectopexy. And there is a lot of drawbacks of the sacropexy also. Okay, there are defecation disorder, constipation, de novo, SUI may be there. Backache is lot of the biggest problem of the sacropexy. and there is a failure rate around 6 to 7% of the sacropexy also, and there may be the obstructive defecation also, and the which is the problem which actually I feel a lot in the sacropexy cases, that is the backache and constipation. There is a two basic problems associated with the sacropexy. So once we started the pectopexy, these two problems absolutely solved down. There is no post-op complaint with the patient of the pectopexy, and pectopexy patient is very much comfortable. And I think it is anybody performing the sacropexy or advanced laparoscopic surgery can easily perform the pectopexy, and I think it is much easier than the sacropexy. So now we have completely switched over to the pectopexy, but the patient having uh, the other, like some kind of the infertility problems, and then we can go into the posterior compartment for the fertility purpose, that from anterior aspect we can do cesarean easily, but after the pectopexy also you can do the cesarean very well, because the mesh is only the 1 centimeter broad, and the lower segment is 6-7 centimeters, so we can easily give the nick on the baby uterus and give take out the baby out. So just next slide, please. Next slide. Who is handling, like, please change the slide. The person who is handling this PPT, please change the slide. Actually, I sent the PPT to the person who is conducting this webinar. So please, next, please. Run the video. Yes. So this is the video presentation, how we do the pectopexy. So just no, for previous video, previous video. पहले वाला वीडियो चला दीजिए, इसके नेक्स्ट पे, हाँ ये वाला वीडियो रन कर दीजिए, हाँ ये. So just lift the UV fold and separate the bladder completely. And if the cystocele is more, so we prefer the pectopexy, and if the rectocele is more, then we can go for the sacropexy. And for the anterior repair, is a very good technique. It is taken care of the cystocele also simultaneously. So bladder should be gone down till the trigone level. So upper part of the cystocele completely taken care, and then the peritoneal incision extend till the lateral pelvic wall and along the round ligament. So once you identify the external iliac vein, and the round ligament is the base, and this obstructed obliterated internal iliac artery is the median limit of the area where we can find the pectineal ligament. And here you can see just bluish discoloration, like bluish. This is the external iliac vein, and just below the external iliac vein there is a pectineal ligament. So this is the whitish structure seen, that is the pectineal ligament. And for exposing the pectineal ligament, you have to just cut off the fat over. This is the obturator nerve, the whitish structure seen. So obturator nerve just below the pectineal ligament is there. So you have to identify the triangle, like round ligament, the base, obliterated umbilical on the medial side, and the extra iliac vein on the lateral side. And this way, both the side is open. Now you can introduce the mesh. And introduce the mesh is the simple hernia mesh we are using. You can use the macroporous, microporous, whichever mesh is available. And I don't find any difference in using both the kind of the meshes. And erosion rate, I think it doesn't depend on the type of the mesh. Actually, it is depend on your dissection. See how you actually well dissected the planes. If you go in the one wall, like in the bladder wall or the vaginal wall, then definitely there may be the erosion. So if you are in the proper plane, then definitely there will be very less chances of erosion or the mesh extrusion, or the person's immunity, I think a little bit play a part in the mesh erosion. But somehow, touch wood, we don't have any kind of the mesh erosion in the pectopexy cases. So the 15 centimeter long mesh, 1 centimeter broad, and in the center it is like 4 centimeter to sit below the bladder to take care of the cystocele. And once we put the mesh inside, then place it properly below the bladder over the cervix, and both the edges are going towards the pectineal ligament. And now you take the suture from the this mesh, and then taking the suture through the pectineal ligament like this way, and then again taking through the mesh. So this will actually place the mesh properly over the pectineal ligament, and it actually does not cut through. If you take only one suture through the mesh and take the suture through the ligament and then tie it up, then it will actually problematic because that may cut through. But you are taking again through the mesh, then it will fit properly, and there is no chance of the cutting through of the mesh, the thread. Both the side we are taking two sutures to secure it well, because this is the only point which is actually taking care of the mesh and the load of the uterus. And after placement proper, you can just, I think one part is not seen, or the mesh should be properly fixed over the cervix and over the uterine part, and it should not be fixed over the vaginal wall, which is actually coming or covering the cervix. Because if you're taking the suture in the vaginal wall in the center, then it may be little, uterus may go slack down. So it should be taken properly suture over the cervix. So then after taking completely suture, then you can just close the peritoneum. And we have to take care of the posterior compartment in every case of the pectopexy. And here we are taking the Muscovy suture, starting from the right side of the uterosacral ligament, and then taking through the lateral pelvic wall peritoneum, and then through the serosa of the rectum, and then through the left side of the uterosacral ligament, 2-3 bites. So it will, and then from the torus of the uterus. So it will actually obliterate the POD and actually treat the enterocele if it is there, and prevent the chances of the future enterocele if it is not there. So, and this actually nullify the effect of the placement of the anterior mesh, because the every person says if you are placing the mesh and lifting the uterus anteriorly, then it increases the space posteriorly and it will lead to the enterocele. So it is the one suture gives the answer of the all, okay, that it will not, it will actually decreases the posterior space again, and then closes the POD and decreases the chances of enterocele or treat the enterocele. And this way actually you can see the final result. Uterus goes very well high up at the zero level, and very few recurrences. Actually I have around 4-5 recurrences only, not much, and that also not too much like the third degree prolapse happen again. It is around one first degree or second degree at last, like. And I think the failure is just because of we have taken the suture through the vaginal wall, and we have not taken suture properly through the uterus or the junction of the uterus and cervix. Because if you have taken the suture through the wall of vaginal wall which is covering the cervix, then actually comes back little bit down, and it actually lead to the first degree or second degree descent of the uterus, I think, because I have analyzed the 2-3 cases which actually come back to me again after pectopexy. So this is for the uterus or uteropexy. Next video will show you how to do into vault prolapse. So just show the next video, please.
Ma'am, there's some lag with the internet, so that's why it's taking some time to change the slides. We've already changed it, but it's there's some delay with the changing on online.
Okay, and if I am just speaking and the video is matching, or it is the delay in that also?
That is
No,
matching.
Sushila, your talk is absolutely in sync with what you're showing, and I think now they're starting with the laparoscopic pectorexy.
Yeah. So we, I need the next slide. Yes, this one. Just play this video.
It is being seen very well, and you can be heard also very clearly.
Okay, ma'am. Okay, thank you. So this video shows how to do the pectopexy in the cases of the vault prolapse. And you have seen the vaginal view of this case. There is a good third degree vault prolapse in this case. So just put the gauze or the sponge on holder into the vagina and push the vault inside, and then separate the bladder from the vaginal vault. And for separation, you have to just see the line, the where actually the anterior and posterior peritoneum met, where you have to just cut and lift the bladder properly, because this plane is very important part to do the vault dissection here, because your bladder was already dissected in the case of hysterectomy, and then there is a little chances difficult to find the plane, and here actually leads to the vaginal wall damage, because we are like little bit afraiding from the bladder and keep our side more towards the vagina, and we actually go into the vaginal wall, and this is actually the chances of increasing the erosion into the vault. Next, we have to separate the rectum posterior peritoneum to place the posterior part of the mesh on the posterior vaginal wall, and here also you have to take care of the planes. And the lateral wall dissection is the same for the pectopexy case. Either there is uterus or not, the uterus is there. No difference in the lateral dissection. But here is no round ligament, so there is nothing to guide you anterior to the round ligament, but remnant of the round ligament is there. On the lateral pelvic wall, you can just directly identify the extra-iliac vein, and just below the extra-iliac vein, you will find the pectineal ligament, and you can easily identify the obliterated umbilical artery also. So external iliac vein and laterally, and the obliterated umbilical artery on the medial side, and here you will find the pectineal ligament. So this actually landmarks you have to be remember, so easy for the easy identification of the pectineal ligament. So both the side you have to open the spaces and open the pectineal ligament well, and then again you need a mesh, and mesh again it will be the hernia mesh, 15 centimeter long, 1 centimeter broad, but in the center it will having the anterior and posterior both 4 centimeter the tags. So this is on the right side, left side you can see the pectineal ligament, this whitish structure which is shown in the center. Now mesh is come inside, and you can just place the mesh, one arm anterior, one arm posterior, and two arms on the lateral side. And here you can just take the suture over the vaginal wall and fix the mesh, and first suture has to be taken into the center. So it will fix the mesh, and then mesh will not be go here and there, and you can properly fix the mesh. So you have to take in 3-4 sutures on the anterior vaginal wall, and then 3 sutures on the posterior vaginal wall, and then on 2 sutures on the both the sides. So this way actually fix the vaginal wall properly in the center, and it will not lead to actually anterior or posterior displacement of the vaginal axis, because we are making a hammock, and we are just not pulling it out, or not pulling or not pushing. We are just tucking the both the sides actually properly, and there is a very good hammock maintained, so vagina and remain in the proper axis and not deviating from the axis, because there is a very uh, common concern of everyone in the pectopexy the vaginal axis will change, and but I think in the sacropexy also you just pull it the vagina highly towards the sacrum, and it actually changes the axis, and actually that increases the urethrovesical angle also, which leads to actually the SUI. And there is nothing happen in the pectopexy, no SUI, no vaginal axis changes. So I think it is all the theoretical things which comes in our mind, but it is very well, vault is very well suspended with the pectopexy mesh, because mesh is not actually, it is a hammock and it is just central free part. So vagina can take its own way, and just it is just suspended with a U-shape hammock. So not at the fixed point, and it cannot like this, it cannot move. So very good mobility in the center at the apical level, and actually it is very free. And once you see after completion of this procedure, the vaginal axis and the top of the vagina should, you can just check it is S3 S4 level, which is actually the normal level of the vaginal vault. So this is both the side fixation with the two sutures and anterior posterior vaginal wall fixation, which will take care of everything, cystocele, rectocele, and everything. And now we just close the peritoneum, and you can just see the final view. And closure is done with the vicryl and the mesh fixation with the ethibond suture. So you can see where is the vault and how we are just taking care and making a hammock. And you can see the vault level is S3, S4 level, not higher, not lower, and it can actually move anterior posterior sideways as the normal level of the axis of the vagina can go. So you can just see, I think last we shown or not. So done, I think. So next slide, please. So this is our experience. Next slide, please. So till now, 2023, we have just updated the data, and 324 women we have till operated with the pectopexy, which includes the with uterus or without uterus, the woman. And there is we have done every patient POPQ and followed up the patients after 1 week, 15 days, and after 1 month and 6 months. So just show the next slide, please. Next slide, please. Yes. So follow up we have done, and 3rd month, 6 month, and 1 year, and many women lost to follow up till the 1 year, but 3 month follow up is very good. I think 90% women have taken the 3rd month follow up, and if you can see, failure rate is very low, and 324 out of next slide, please. Most of the cases are 3rd degree prolapse. That is the 71%, and 24% are the stage 2. Next slide. So no. First slide, please. Previous slide. You have come directly to the conclusion. Previous slide. The result one. Yes, this one. So here you can see the result of our study that 324 cases, 66 patients were lost to the follow-up, and out of remaining 258 patients, only 9 patients have the recurrences of prolapse. Out of 9 cases, you can see 4 cases had stage 1 cystocele, 3 cases has the stage 2 apical prolapse, and 2 cases has the stage 1 rectocele. So results are promising with the 96% all over success rate and high patient satisfaction without any complaint of backache, constipation, dyspareunia, SUI, or the bulging symptoms, and very good suspension in cases of the procedentia also, because I think just I have to see how many patients are for the procedentia, but around 10 patients have at least in this data is the procedentia, and that is also doing well. So you can see this way, paclitaxel is actually effective technique and without any side effect. So next slide. So everybody can perform the pectopexy who is doing good laparoscopies, and we should learn both the techniques, sacropexy, pectopexy, and even lateral suspension of the uterus, where we have not to fix the mesh anywhere. We just pull out the mesh through the abdominal wall. So either of the technique may fit for the specific patient, and in the specific case, for specific region, we may not perform any specific technique. So actually, we have to learn each and every technique and choose the best for our patient. So I think the last slide, please. Next slide. Next slide. So laparoscopic pectopex is good alternative to the sacropexy, and as already I speak about that, there is no defecation disorder, no backache or neuralgia in the long term follow up. So I think the pectopex is good technique, and we can do it easily. Thank you so much for allowing me to present this study and this technique here, and uh, thank you so much. So you can ask if any queries are there.
Excellent talk, Dr.
Thank you.
Sunita. Very nice talk. And as always, you commanded and expressed very beautifully all your experience and your follow up of your patients. I have just one question: that have you,
Yes, ma'am.
what was the rate of SUI subsequent to your procedure?
Pectopexy, no patient came to us with SUI.
Okay. And all what you
I
said,
think the anterior compartment placement of the mesh is actually protective, and there is a lateral wings also, lateral arms also that actually may protect to development of the SUI. But definitely, I have seen in my patient of sacropexy the SUI. 2, 3 patients I have seen they develop the sacropexy. Even after doing the faculties in the Rajendogyne sacropexy, I have seen in that cases also the SUI. And my case is also shown the SUI because I think the angle of the vagina is changed in the sacropexy more because we just pull it towards the sacrum, and in the reduction of the prolapse in the sacropexy, I think we have to pull little bit. Here we don't have to pull, and the mesh is very much relaxed, and it is like a very good hammock. So uterus or the vaginal vault actually is very well free in the center. So it accommodate the herself, like the vagina accommodate herself and very much in the natural position, which actually feel in doing the cases, both the cases I am doing.
and
So
15 centimeters the length of the mesh that you take,
15 centimeter,
and 1 centimeter breadth.
No, total
1
length.
centimeter broad.
Yeah.
Yeah, 1 centimeter broad at the edges, and in the center it is 3, 4 centimeter to sit properly below the bladder to take care of the cystocele.
So
Very good.
basically, you're putting a mesh in the center all around in case of a wall prolapse.
Mesh in the wall prolapse there anterior arm के साथ
Anterior as
posterior
well as
arm will be also there.
posterior and lateral fixation.
Yeah. So there is a clover leaf pattern mesh is actually there, cross type or clover leaf, anterior, posterior, right and left.
Yes, excellent, very nice. I think we are absolutely convinced by your method, and I think most of us who would be commanding the skill very soon now. And for everybody who's attending this after watching you. So,
I
Avinash,
think it, yes.
I think so. Out of the people who are over here right now, how many of us are doing pectopexy?
Yeah.
I think everybody is doing, no?
Oh, no. So
I'm
I
kind
think
of
Avinash,
like
we call it because I think we're running late, and we must
Yes.
thank Dr. Bhaskar, Doctor and his team, right from Dr. Ashish Kale,
Yes.
Dr. Amog, Subhash Malia, who was in touch with me. I think all of you have done a wonderful job of being in touch with us and galvanizing the whole program
Fantastic.
so meticulously. A big thank you to you and to all the wonderful speakers. And of course, Manjula, we have missed. A
Yeah,
big
we are missing Dr. Manjula.
yeah.
Otherwise, we would have hoped to
So,
listen.
this is all yours, Dr. Bog. Now, Aruna, you want to say something?
I think so. We have had an excellent, complete speakers over here who spoke to us from right from Birch corpus suspension to your pectopexy, as well as fertility enhancing surgeries
Yes.
by Dr. Sejal. And it has really, they've covered a wide spectrum of diseases that can be tackled with these methods. And excellent talk. And definitely kudos to Dr. Bhaskapar for organizing this thing all across India. He has been organizing the webinars, and
Yes.
this e-endoscopy definitely a brainchild of Rishma Pai. And he's continued with that even during his presidency, and now we are having it as a webinar also. Thank you
And,
very much for giving us a chance to be there, a part of this.
and we would like to wish Dr. Bhaskar Par all the very best.
Yeah.
Um,
Thank you
all
so
the
much.
best for the.
Thank you so much, Aruna ma'am. Thank you so much, Malvika ma'am. And special thanks to all our presenters for sharing their expertise and contributions to the success of the session. Their dedication to advancing surgical techniques was truly commendable. Now, following this tantalizing video presentation session, which brought about a lot of queries, questions, let's move on to the next session, which will be more insightful and a stimulating discussion on laparoscopic approach of adnexal masses in perimenopausal age group. So, the role of moderators extends beyond facilitating the conversation. They help us delve deep into the nuances of the surgeries for adnexal masses and provide insights and guidance that are essential for us, the medical professionals, and patients alike. So, I have the pleasure of introducing our esteemed moderators for the panel. Uh, our first moderator, Dr. Vidya Bhatt ma'am, a distinguished
Amok, make it very
gynecologist.
short. Make it
Yeah,
very
a
two,
distinguished
three sentences.
gynecologist known for her comprehensive approach to women health and commitment to advancing surgical techniques in laparoscopy. Her experience in laparoscopic surgery and her dedication to patient care has made her a trusted leader. Joining Dr. Bhatt is our second moderator, Dr. Meenu Agrawal ma'am, a renowned fertility specialist and laparoscopic surgeon known for her wonderful hysteroscopic techniques as well and innovative approaches to complex gynecological conditions. So, with this, I invite our moderators, Dr. Bhatt ma'am and Dr. Agrawal ma'am, and quickly introducing our panelists for today. Dr. Anupama Sethi ma'am, a renowned gynecologist known for her expertise in laparoscopic surgery in women health. Dr. Jayamala Kumarave, a pioneer in fertility enhancing procedures and a strong advocate for patient-centered care. Dr. Priya Gupta, an accomplished laparoscopic surgeon with a focus on minimally invasive techniques for gynecological conditions. Dr. Priyanka Garg, a dedicated practitioner specializing in advanced laparoscopic procedures for adnexal masses. Dr. Polly Chatterjee, an experienced gynecologist and laparoscopic surgeon with a passion for innovation and surgical solutions. Dr. Ashwini Kalyankar, a respected expert in the field of endoscopy and champion of women health initiatives. Dr. Amrita Tandon, a leading fertility specialist known for her compassionate approach to patient care and surgical excellence. So, with this, we bring the panel together and I hand over the panel to our moderators, Dr. Meenu ma'am and Dr. Vidya ma'am. Thank you so much.
Um, Thank you so much, Amok. And thank you, Dr. Meenu, for uh, agreeing to be a partner with me in this panel. I know it's very late now, but I will try to keep the panel very short and I will just keep 4 questions. Are you okay, Amok? Just 4 questions, and I'm sure my panelists also will agree with me because they are also
Recording
hired in
stopped.
the after the fag end day's work. Now, at the outset, my sincere thanks to Bhaskar and the entire team for giving me this opportunity, and also wishing Bhaskar all the best. And
Recording in progress.
I'm sure you'll make it, Bhaskar, with so much of efforts. And more than anything, it is your charm and charisma and your the integrity you have and the kind of work you have done for Foxy. I think you should make it, and we all will work towards that. So, for the panel discussion, my co-moderator is Dr. Meenu, and she does not require any introduction because she has made us proud by getting into the European Society. Now, the panelists have been already introduced. So, we just go to the adnexal masses. What is it? It's an anatomical reminder. It shares the pelvic space. It sometimes could be an intruder, sometimes not. So, it could be a full bladder, it could be feces, inflammatory, neoplastic bowel masses, enlarged lymph nodes, masses of nerves, vessels, and bones. Pancreatic pseudocysts can also sometimes sit here. Ectopic kidney, which are again intruders, and accessory spleen. So, for any adnexal lesion, we have to decide the origin. Where is it from? And is it tubal? Is it peritoneal? Before making a proper decision to go ahead with that. So when we compare a lady with premenopausal and postmenopausal women, we have normal ovaries in premenopausal, then benign tumors, borderline tumors. Whereas in postmenopausal, normal ovaries can be there, benign tumors, borderline, yes, but invasive cancers are really sort of making you intrigued. So I think we should see how you can do the diagnosis. And when you want to do the diagnosis, you should think about benign, non benign, primary malignant ovarian tumors, and secondary malignant ovarian tumors. So, and it can be a gastrointestinal one also. And let's quickly move to the case number one. Dr. Meenu, I would request
Sure.
you to take over.
Sure, sure. Thank you, Dr. Vidya. We are very old friends. So
Yes.
in
Oh, yeah.
endoscopy, and yes, and thank you, Dr. Subhash. Thank you, Bhaskar, very much. And you are doing very good. Your canvassing is going very well. And of course, I can see very familiar faces here, both in the panel and as the chairpersons earlier, Dr. Malvika, Dr. Aruna Tantia, and of course, we have the chairpersons. I know most of them I know very well. I know Anupama very well, Jaymala, Priyanka I know very well. Amrita, of course, is a good friend's daughter, Ashwini and Polly Chatterjee. So, first case for you, and Amog, thank you very much for the kind introduction. A 42-year-old, she has no complaints. She just comes with an ultrasound report. She went for a health checkup and she had an ultrasound done, and she's come with this report of 4 centimeter simple cyst in the right ovary. She has a, somebody, some friend of hers who had an ovarian cancer. So she is very much worried that whether I've got some kind of a cancer. Her endometrial thickness is 15 millimeters. Okay. So my question to the first, anybody can answer, the first panelist is, will you do a color Doppler for her, or will you just counsel her and not do anything about her? What all will you do for her?
Hello, Meenu ma'am. Dr. Ashwini Kalyankar over here.
Yes, Ashwin.
Uh, yeah. This is little thin line, I guess, between the benign lesion and the malignant lesion. Being a 42-year-old female, asymptomatic, come with 4 centimeter of cyst. So I guess thorough sonography is the first line of management rather than jumping into any other investigations. TBS or good TBS in good hands will be the ideal one.
So would you do a color Doppler with the ultrasound, or you will just do a simple ultrasound for her?
Ma'am, at first, simple ultrasound.
Anybody
Ma'am,
else?
can I, ma'am, can I
Yes,
add on?
Please, Anna.
Ma'am, yeah.
Dr. Priya. Mhm.
Yeah, ma'am. Sorry to interrupt in between. Actually, in this case, I think though the patient is asymptomatic, whenever a patient comes to our OPD, like number one, what we are being taught, we have to focus upon whether we are able to find out any clinical signs or symptoms. In this case, the patient is totally asymptomatic, and the size which has been given is 4 centimeter. So usually, such kind of cysts are maybe benign. It's a gray scale, like Dr. Ashwini has said, but color Doppler is mandatory with a thorough TVS and TVS both simultaneously, because in color Doppler, we may pick up some unusual blood flow, which may point out towards the indeterminate lesion or maybe the future likelihood of the pregnancy, positivity towards malignancy. So, such patients, if the Doppler turns out to be okay, we can counsel the patients accordingly. We can keep the patient in close follow up, go for a revision, TVS again with the Doppler in the subsequent settings. I think so.
So would
Can
you
I
also
interrupt?
like to know about the menstrual history? Are we doing a premenstrual scan, or is it being done in the post-menstrual phase? Because in the post-menstrual phase, a 4 centimeter cyst with an ET of 15 millimeter, we need to actually have a look into everything.
Have a look at it. Yes.
Even
Yes,
at
we have to
27th day. She's premenstrual at the moment.
Yeah, at premenstrual. So, like, I think it's absolutely normal. It's only the hyperestrogenic thing is there, which is causing her ET to be 15 and the simple cyst of 4 centimeter. And after menses, we can review her again. If the cyst abolishes, then it's fine.
Yeah, true.
Would
Agree.
anybody think about endometrial biopsy? She has a family. She has somebody who had an endometrial cancer. She is very much worried. So
And
would
it should
advise
be
an
done.
endometrial
It should
biopsy?
be done.
Again, ma'am, I think, it would depend on whether she has any history of abnormal uterine bleeding. Secondly, if she has, if the scan was done in the premenstrual stage or the postmenstrual, so if it was like you said premenstrual, then we should repeat it on day 3 or day 4 of the menses to see if the lining is now thin. If it still remains thick, then we should do a hysteroscopic guided endometrial biopsy to rule out any hyperplasia.
The characteristics of the endometrium also. Is it like what does it appear at? How is the blood flow of the endometrium? Does is it a cystic endometrium? Then, ma'am, even these things can guide us over there.
Generally, these cysts, as Dr. Anupama rightly said, they are secreting estrogen. They are follicular cysts, and that is why the endometrial thickness could be more. So, anybody who would advise the patient to go for a cystectomy, or everybody would go for a conservative management in this?
Conservative.
Conservative management
Conservative one.
and follow-up.
Conservative one.
Conservative.
Conservative management and
Conservative.
follow-up.
Follow-up. All right.
So
So,
when do you think a conservative management, or when do you want to do a surgery?
okay, suppose
If a
in
cyst
this conservative management, 3 cycles have gone. She is getting her cycles, but after 3 months, also the cyst is remaining. See, it is still there. 4 centimeter cyst, it is still there. She is getting worried. What would be your next line of treatment?
Then it's a laparoscopy, ma'am.
Ma'am, you
Yeah,
can go
go
for
for an operative.
125
Because that time
estimation.
these are para-ovarian cysts also.
Yeah,
They don't
common.
respond to like the one which we are doing right
Yes.
now.
Yeah, so sometimes they can be serous cyst adenomas also.
Yes.
And
If the patient is getting worried, maybe you could advise her to go for a laparoscopic surgery. So that is one option. Anybody wants to add something to it?
Ma'am, we can add upon the added advantage of going ahead with the tumor marker, CA125,
Yes.
along with this simple cyst monitoring. If the patient offer a conservative approach, then it's good to get it done so that we can have a repetitive evaluation of the same in the subsequent follow-ups.
I agree with
Yes.
you. Totally agree.
Same,
Good
I
point.
agree.
That
Great
will
point.
definitely reassure the patient when the CA125 is normal. So,
Yes.
yes.
But even in mucinous cyst adenomas, ma'am, CA125 is normal, which we see. This doesn't look like to be that, but we have many cases of mucinous cyst adenomas in which CA125, each and every marker was normal. But still, due to the suspicious nature of the lesion, we went in for a laparoscopy.
In any case it remains for more than like 3 months, then you have to do laparoscopy.
Yeah.
Yes,
If
Dr.
it is
Vijay?
an if it is an unilocular cyst, any size or solid components are not present, and if present, if less than 7 millimeter in diameter, there is presence of acoustic shadowing, and there is it's not an it's unilocular only, so there is no blood flow also.
Correct.
I think we don't need to do anything according to the IOTA tumor analysis study.
Yeah,
It's
complete
benign.
risk malignancy index should be assessed before
Definitely.
going for a conservative management.
Yes. So it goes into the category of a benign cyst or
Yeah.
benign cyst which is consistently present. The patient may get worried, and you can still go for a laparoscopic surgery knowing fully well that it is a benign cyst. It is not malignant. So I agree with you. She IOTA guidelines, it is benign, but since 3 cycles she has not responded, or maybe the cyst has slightly grown bigger in size, there is I mean, it is all right to go for leper. Anybody says that we can just leave the cyst, not do anything about it?
No, follow-up has to be there.
Yeah, I think they're very clear on whatever they're saying, and great points on this aspect.
Correct.
So we move on to the second case. 43-year-old with mass per abdomen since 1 year. Ultrasound shows a large, well-defined heterogeneous cystic lesion of 7 to 5 centimeters in the left ovary with echogenic strips, areas of dense shadowing, and a focus of ossification, likely diagnosis of a dermoid cyst. So management, how would you go? Conservative, surgical, and why?
And for dermoid, it is
Dermoid
always
is
surgical.
Always
always
surgical.
surgical.
That's
Surgical
right.
laparoscopic
Ma'am, it's
cystectomy for
We need to
derm.
go for tumor markers as well, ma'am. Like
Yes.
for all these
Alpha
cases, we go for
fetoprotein.
CA125, alpha fetoprotein, beta HCG, and LDH. Usually in dermoids, the LDH rises. So for any kind of dermoid, we go in for a laparoscopy.
When do you want to
And then
conserve the ovary and when do you want to remove the ovary?
Now that she's 42 years old, I think we can go ahead
Can
with it.
Correct.
I think if we have a fairly
yeah.
a
yeah,
good
we should remove the ovary.
tumor,
Yes,
yeah.
Yes.
in this case,
And
we
if
Size
it's
is
a
like
confirmed
7 by
diagnosis,
something
ma'am, we can
centimeters. It's a big one.
yeah.
Yeah. Yes,
So
one
of
by one,
course, in a
please.
younger patient where we're looking at a fertility preserving surgery, we would
Yeah.
definitely prefer to do a conservative cystectomy. But in
Yeah.
a 43-year-old, maybe we can remove the ovary and
Half an hour.
because of the slight chance of malignancy.
Okay.
And
Also,
if the
Anything if
size
the
tumor
is big
size,
one, madam.
anything if the size is too big or torsion, what would be your management?
Again,
can also
cystectomy,
remove it.
ma'am. In 42, we remove the ovary. But for younger patients, even in torsion, we retort it. And if the vascular supply is good, then we can even preserve the remnant ovarian tissue, whichever is possible.
Would you like to remove the cyst if it is torsion?
Yes, even
Definitely.
in
Yes,
torsion,
madam.
ma'am.
Yeah,
Yes,
you have to remove
has
it.
to
Remove
be,
the cyst.
it has to be
remove the
removed.
cyst, ma'am.
Yeah.
Debulking has to be done before
We
fixing
unclose
up.
the ovary and then remove the cyst.
Any would you like want to do some CT or MRI in this case before, or would you like to straight away say no, I have done ultrasound, let me not
Ultrasound and tumor
burden.
markers are quite good
Yeah.
for a dermoid,
Yes.
ma'am.
So not all cases require CT and MRI,
Yes,
but
yes.
only in cases where you really suspect something else, then maybe you would want to add up to the CT and MRI.
Yes.
So advanced diagnostic imaging may be crucial for detection in adnexal masses, but not always. You would want to consider that. Then, what is the risk of malignant transformation? And that is RMI. And can you? I will put the IOTA rules, but will you want to discuss on the IOTA rules here?
If there are presence of a irregular solid tumor, if there is ascites, if there is at least 4 papillary structures, or there is an irregular solid multilocular tumor and very strong color flow, in those cases, it's an aim feature of the IOTA rule. And in those cases, we have to think about malignancy and we have to involve a gynecological oncologist while doing the surgery. But if there are B features, B rules like unilocular cysts, like no solid components or less than 7 millimeter size solid components, and presence of acoustic shadowing, and smooth multilocular tumor with largest diameter of less than 10 centimeter and no blood flow, that seems to be a benign cyst, and we can go for laparoscopy in a normal gynecological setting.
Yeah, the B rules and the M rules. One thing is you should think of the risk of malignancy index. Where
Index.
you have CA
Yes.
125 and then you score premenopause, postmenopause.
That
Yeah. And then the B and the M rules you have to keep in mind and then go ahead accordingly for that. And of course, the features of which Dr. Polly has well mentioned everything. So, and the features of malignancy, what all you see, the strong blood flow, papillary structures, and then, of course, unilocular, multilocular. Over to you, Dr. Meenu, for the next case.
So a 42-year-old Nali Gravida, she's infertility. She has had 3 failed IUIs and 1 failed IVF. Now she comes with an ultrasound. You do an ultrasound and you find that there is a mass in the right adnexa. It's a unilocular mass. It has got a ground glass echogenicity. You put a color Doppler, moderately vascularized. It suggestive of endometrioma on ultrasound. Uh, how many of you would think to go for straight IVF? How many of you would think to go for a surgery? How many of you would think that you would do surgery and IVF, maybe one after the other?
Ma'am,
So,
what would be the size of this
Size of
endometrioma?
And
uh,
AMH level.
Yeah, and of course,
Yeah,
AMH
around
incidence is
4
42.
centimeters. Yeah, around 4 centimeters, and AMH is very low, below 1.
Ma'am,
Then
any previous
Ma'am,
history of surgery?
there's no previous history of surgery, no.
Surgery.
yeah.
Okay.
So, ma'am, if the
Very
AMH
good.
is
Definitely
quite
it's a
You
catch
do
22
get such patients
situation,
now.
but
So what do you do?
yeah, but probably for her with her low AMH, advanced age, an OPU first,
Yes.
preserve the do fertility preservation and then do the surgery. You could follow it up with the embryo transfer. That
No,
would be the first.
I think there's no need of, because she'll anyway go for donor ovum. Like,
Yeah.
That's the
yeah,
other
because
thing.
See,
Yes,
that's the
yeah,
exactly.
thing,
because
ma'am.
She's
she's
not
Because
agreeing.
now
She's
in
not
newly
agreeing
failed
for donor.
IVF,
She
she
says, I
won't
want
be able
my
to do with her
androgen.
ovarian
And with
cancer.
approaches.
So
yeah,
then
very
doing
low
surgery
image,
also might help.
very low. What do you say? Egg reserve. I don't think so. She can go for that.
Practically, ma'am, yeah,
Very
to get egg
Her
from
AMH is one. She does not want to go for a donor egg. She's very clear she wants to go for self only. Okay.
ma'am, it's
Number one, how many
But
of you
once,
go for the surgery? Whether
ma'am,
before
once we
the
go for
pickup or
surgery,
after
there
the
are certain other factors, ma'am. And endometriosis, endometrioma is just the tip of the iceberg. There are so many other adhesions and all multi things which can be taken care
Then
when
it's
we do a surgery.
then, ma'am.
Here, her main complaint is infertility, not pain. So I guess
ma'am,
treatment
ideally we should
according to
go
the
for a
infertility
pickup
point
followed
of
by
view
surgery in
should be
such
Yes,
a
there.
case, ma'am.
yes,
absolutely,
And the
yes.
Yes,
concern
absolutely,
is
absolutely.
in priority fertility, and she's in context for the same.
And
So we
because her
should go for
age
pickup.
is,
Yeah.
yes,
Yeah,
because
you
her
want
age
Because
to
is,
even if we do that endometrioma surgery, when we are stripping off the endometrioma, in that case also there's a lot of potential follicular loss in the subsequent cycle. So it's good to go for a pickup first,
pick up
then a
first.
surgery, and then we can think of going for an IVF, and that may yield a better live birth outcome in such a case.
So
Yes.
I
and
agree with you that if we have to go for the surgery, then go for the pickup first. But
Yes.
most of the
Yeah.
guidelines
Even
now,
now, sclerotherapy has come up now. It is not always stripping or cystectomy, just pushing in alcohol into the cyst.
I,
Is
I
the
think
new
so.
thing
Dr.
which is
Horace
happening.
Raman has been doing it. He
Yeah,
has got
that's
a
supposed to
very
be
good
a
series
with Dr.
where
Roman.
he's been injecting
Uh,
alcohol inside the ovarian cells and all those patients who are wishing to conceive or infertile.
1% ethanol.
no,
And
Dr.
then taking out and suctioning it
Yeah.
again and without doing anything.
Yes.
And then later on, the whole of the cyst gets reduced.
Yeah,
Then
ma'am,
both.
Dr. Sandesh Kade is doing the same thing. We had a webinar
So
yesterday.
it is basically a big series from Dr. Roman.
Yeah.
but most of the publications have now from ASRM have shown that if you have an endometriotic cyst which is not causing any pain, she is infertile, you can without any surgery, unless the cyst is that big that it is coming in the way of your surgery, or you are suspecting any kind of malignancy, or she has severe pain. So if all these three things are not there, you probably could avoid the surgery totally and straight take her for IVF, either with her own egg or with a donor egg, if she agrees for it. You can, this is Dr. Vidya Bhatt has very kindly put the videos, nice videos that she is sharing with us. And this is the surgical video of the same patient. Probably she was initially did an IVF, did not work,
Yes.
and she was having
Did an
pain.
IVF
That
and
is
then
why it was performed. Sorry?
yeah. Did an IVF for her and then did a
Correct.
cystectomy
Thought
and
as
then embryo transfer.
right,
And she
right.
conceived also.
Great.
That is really good.
Very lucky.
Yeah,
we
yeah, very lucky. I did get a
have
blast and I did an embryo transfer.
So
Yes.
excellent.
anybody think of doing a puncture at the time of the ovum pickup and just do a drainage of the endometriotic cyst?
Hmm.
And
No,
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 ma'am.
not at all.
Never, ma'am, not.
not at all. Not at all.
so I agree. I mean, I am I also agree with everyone. And suppose you
Infection.
accidentally puncture the cyst, you are doing the egg pickup, you accidentally puncture the cyst. What will you do next?
Antibiotics, ma'am, because chance of abscess formation
Infection.
is there,
Yes.
infection.
Getting infections.
Put it on antibiotics.
A
And
thorough intraperitoneal lavage at the time if the puncture happens somehow.
One should
That has
take
to be.
a patient laparoscopically and do the lavage itself.
Actually,
Yeah.
we don't
Wash
need
the
to go
needles.
that radical.
And since the needles are very small, that much of puncture may not occur.
Does not
Maybe
harm the
Wash
yeah,
patient.
the
yeah.
needles.
But your needle may go. That the chances
Yeah,
may ask for
that
a
is
new
what
needle.
it is.
Yeah.
That is
Ask
the
for a new
problem.
needle, change your test tubes,
Yeah,
then
yeah.
just change
That
the
Take
would
the
needle.
test tube and
Yeah,
change the
change
needle
the
or
needle
flush
and
your
then
needle and then go for the next side.
yeah.
So you people spoke about the sclerotherapy also, and then we all were very clear on that if you are doing surgery, it should be after the home pickup and then freeze her eggs and then go ahead with transfer after treating her surgically. So depends upon the outcome. So I mean everybody is on the same page on that. Now let's go to the fourth. Of course, ovarian sclerotherapy, 5% ethanol, high recurrence rate is there, lower cure rate, not routinely advocated, but in low AMH patients, this would be worth a try because basically we want to conserve the ovarian follicles. So this we can try this. Get any, I mean, we should get, I mean, we have to look forward for a lot of studies in this, but still, I think we can give some hope to our patients saying that, okay, let me try this and maybe this should help you out. So case four, Dr. Meenu, and I think this is going to be the last case. After we have discussed a benign one and then dermoid, which we see routinely, and then of course endometrioma. When the moment endometrioma comes, there is a lot of discussions and controversies. And let's go to this again. Patient, over to you, Dr. Meenu, for the fourth case.
Okay. She's a 41-year-old lady. She came with abdominal distension. She has dyspnea, breathlessness on exertion. Ultrasound shows solid hypoechoic mass with focal areas of calcification in the left adnexa with moderate ascites. She is para 2, she has two children, and she's just come with these complaints. Yeah. How will you manage? How will you investigate further? And what is the differential diagnosis as per the ultrasound report?
Ma'am, the case as such appears to be a malignant adnexal
Okay.
mass because the patient is presented with ascites. It's a solid mass. Number three, the patient is dyspneic. So there may be lung metastasis. We need to go for a thorough examination, the proper history taking of the previous risk factors for the same. Any family history has to be taken into account. A thorough pelvic examination followed by a radiological details like it has been given, but we should also go for prior CT to check out for the metastasis in any other organs like lungs, brain, and we can also think of going for this evaluation of all the tumor markers to have a thorough differential diagnosis. And as such, after the evaluation of the tumor markers, the risk assessment has to be calculated. We may also take, because as per the guidelines, it also says that you need to involve a gynec oncologist if the RMI score is more than 200 or if we have significant elevated CA125 levels and we have a likely suspicion of higher malignancies. So it is good to have a combined opinion, a combined strategy has to be taken. And in such kind of cases, the laparotomy with a midline incision and a staged approach is recommended rather than going through laparoscopically until unless it is with the expertise of the surgeon, with the experience of the surgeon, I would say.
A multidisciplinary approach should be there in these cases. And we should always go for the tumor markers, definitely, and calculate the RMI. The That is a risk of malignancy index. It should be high in these cases. And definitely, if it is more than 200, in those cases, we have to think about the malignancy and go about it. Maybe a CT scan, PET CT scan may be helpful in these cases.
So, would you go for a CT or a MRI for her?
CT for the extra ovarian any metastatic or any other diseases, and MRI to see the what type of tumors we have. So CT for the extrapelvic lesions.
Any role of CT guided biopsy in these cases?
No, ma'am.
No, no, no.
Ma'am, no.
Can actually take a CT guided fluid,
Fluid,
record a
yes.
fluid,
You
or
can take
from the
fluid.
solid portion. From the
For
solid
diaphragmatic
portion,
fluid,
one can take a biopsy and do a ISC on that. One would be able to come to a whether there is because most of these malignant tumors would be having a mutation.
yes.
And also, ma'am, we can, if we are planning to do a laparoscopy, we should also discuss the role of frozen section
Yeah.
in such
Yeah,
cases.
that is the laparoscopy, but here you are having ascites.
Yes, in
You
this
are
case,
having
of course not.
ascites.
If
So
there
there
is a
is no
less
time
likely,
to tapping
yeah,
the ascitic fluid and
yes.
go for the
The type of
paracetamol.
CA and then chemo if necessary, and later
Yeah, so you
later
do
on,
a
yeah,
Laparotomy, yes.
you do
laparotomy.
the anterior
Staging.
chemotherapy and then followed by reduction this thing.
Reduction.
So
So,
I just wanted to share over here, with permission of our moderator.
Definitely,
I
ma'am.
once encountered a young woman keen to become pregnant, nulliparous woman, bilateral adnexal masses thought to be endometriotic cyst since she had very severe pain during the periods also, and even the sonography reported it to be endometriotic cyst with some little bit of debris inside. Once we went and laparoscopically, what we found was a large adnexal mass on the right side, and the left mass was also quite comparatively 5 to 6 centimeter. We put in a needle and we could not aspirate any endometriotic fluid. Neither was it looked like a solid thing. So, and there was no dermoid material that could be aspirated. Hence, we had to talk to the patient party and remove the whole of the mass, adnexal mass of one side. We sent it for biopsy, and to our surprise, it came out to be a myeloid, extra myeloid sarcoma. That is the precursor of blood cancer, leukemia. That was the first finding it came.
Yeah.
And this patient then went on for she developed leukemia 3 months after it. And then she underwent chemotherapy as well as bone marrow transplant. And her other ovary became normal. Now she's leading a very normal life about 2 years later.
So that is a very nice case, Aruna madam, that you
Yeah, I know.
discussed.
So
So
the thing is that it should
One
come in a
take
DD,
home, yes,
yeah, yeah,
one
yeah.
take home
which we
message
had
for
never thought.
Yes.
right. So one take home message for everyone, all the doctor people who have joined in for this panel, is that whenever we find an adnexal mass, patient comes for infertility. Forget about the infertility part, just concentrate on the adnexal mass. Rule out malignancy and then go ahead for the fertility management. So that is a very good case and a good take home point on this.
Yes, yes, Dr. Minu, I agree with you that first thing we'll have to consider her and then her progeny.
Correct.
So yeah, so that should be our approach. And all my panelists, you people did a wonderful job. Every aspect and every point was mentioned, and in fact, more than what I have put, you people have given the input. So thank you so much, and thank you, Minu, as always, for such a nice coordination. We don't practice at all. We just coordinate. That we understand each other so well. And Aruna madam, thank you so much for sitting through and giving your input. So sweet of you. Even this fag end 9:15 we are sitting and with so much of
Actually,
interest.
I am learn. We all learn. We are learning from such an extreme
Everybody learns.
family.
So sweet of you, ma'am. Thank you so much, and
Thank
thank
you
you,
so much.
Bhaskar,
Thank
and
you, Hema ma'am. Thank you, Meena ma'am.
Thank you,
Thank you
Meenu
very
ma'am.
much,
Thank
thank
ma'am.
you
you,
to all my
Thank
panelists
Thank
and
you.
yeah,
Meena
for the
ma'am.
great
And
job.
thank you, Dr. Bhaskar Pal, for
Yeah.
giving us this opportunity.
Yes.
And
Thank you.
best wishes, Bhaskar sir, for the upcoming elections. We are all there to help you.
Yes, we are all with you. Yeah.
Yes, we are all with you.
Yeah.
And
All
thank
all
you,
with you.
Amog.
Yeah.
Thank you, for Amog, for
Okay. Thank
conducting
you,
so
ma'am.
well and so
Thank you.
sweet you
Thank
are.
you.
Even though we were trying to misuse the time, you were controlling us. Thanks a lot.
Thank you, Dr.
Thank you so
Vidya,
much,
for
ma'am.
being such a good co-moderator
Thank
with
you,
me.
Amol.
Prepared all the slides. Your videos were so good. So thank you for all the efforts that you take for teaching. And whenever, once I was doing a book or something and I needed a chapter urgently, I just told Vidya, I said, I want a chapter on this particular topic. And lo and behold, in 48 hours, I get the chapter from her.
Thank you.
She
Thank you
is
so
so
much.
academic
Thank you,
and
Thank
so
sir.
you.
good.
Nashkar,
Yeah.
all the best.
That is because Vidya has got 10 fellows, huh?
Only.
Bhaskar, you're
She,
mean.
she
You're
only
mean.
has to she only has to whip them.
Yes. And thank you, Bhaskar.
Mean you are,
My
Bhaskar.
pleasure. Thank you all for your time and
Thank
your
you, sir.
inputs. Thank you very much.
Oh,
Thanks.
thank you, sir.
Thank you. Thank
Bye
you.
Thank you,
bye.
sir. Thank you, sir. Thank you, Dr. Subhash.
Yeah.
See you peeping through the window.
Thank you,
Yeah.
Dr.
He's from the OT, he's operating there and coming out.
He's in the train right now.
Not from the
Oh
OT.
my God.
He's operating.
Yeah. Okay. Okay then.
Great.
Okay.
Bye,
Okay.
sir.
Thanks
Right, right.
everyone.
Good
Great.
night,
Thank you
sir.
so much.
Night.
Thank
It
you.
was a
Good
wonderful
night.
session. And as we come to the fag end of this wonderful, tantalizing, and rapid fire yet elaborate session, it is my privilege to extend a heartfelt thanks to each and every faculty member today, right from Dr. Sunita ma'am, who was insightful and gave wonderful suggestions regarding various aspects of the practice, to our chairpersons, Dr. Aruna ma'am, Dr. Malvika ma'am, who summed up each and every surgery so eloquently
Ready?
that everyone understood it. Thanks to to all the presenters, Dr. Malaraj ma'am, Dr. Manjula, we miss Dr. Manjula ma'am, Dr. Sejal ma'am, Dr. Sushila ma'am. You all presented such wonderful surgeries and all the practical tips for us young endoscopic surgeons. A big thank you to our moderators, Dr. Vidya ma'am, Dr. Meenu ma'am. It was such a wonderful panel which highlighted all the important aspects that we encounter in our practice day in and day out. And a big thank you to all the panelists who were crisp to the point, told about only the points that we should practice without any unnecessary reviews and studies which we generally do not follow, but all the practical tips that we require to practice in our day to day laparoscopy practice. And last but not the least, to all the delegates who joined in and took out time from their busy schedule to attend this wonderful webinar series, the ENDOVISION Chapter 4 on laparoscopy, especially the Eve edition, the wonderful Eve edition. And a big thank you to all the academic partners and all the people associated with conducting the webinar in such a wonderful manner. I would fail my duty if I do not thank personally Dr. Subhash Malia, who helped me out in managing and contacting everyone for this wonderful workshop. And at last, I would like to appeal to everyone to support, vote, and support for Dr. Bhaskapal sir and have a wonderful Foxy president in the years to come. Thank you so much.
Can I make
Thank you,
one
Dr.
Thank you
Amok.
so much.
Can I make one appeal?
Sure, sir. Sure, ma'am.
I'm going for the vice president Foxy
Yes.
election.
I'm so
All
sorry,
the
Election.
best
ma'am.
to
No,
you.
that's all right. 2024. So please give me your love and blessings and support.
Sure, Meenu.
Definitely, ma'am. We are there
All
for
the
you.
very best, Meenu. All the very best to Dr. Bhaskar. Bhaskar, Meenu, all the very best.
Thank
Best
you.
wishes.
Thank you.
Thank you.
Thank
Thank
you.
you all. Have
Thank
a
you, Arun.
wonderful night.
See you again.
See you
Thank
soon.
you. Thank you, Aruna.
Thank you.
Thank you.